Hi, and welcome to Integrative Cancer Solutions with Dr. Karlfeldt. A cancer diagnosis is one of the hardest slap in the face imaginable. All of a sudden, you have to become an expert in cancer and its treatments because your life depends on it. Oncologists, family, and friends are pushing you towards chemo, radiation, surgery, and yet you feel there are additional solutions out there. You don't feel confident in that only traditional therapies will take care of it. You may, as I have, seen family or friends quickly go downhill from harsh medical treatments. There is a better way. I invite you to listen to stories from real people fighting cancer successfully through powerful, integrative, and holistic methods. Learn what they did. This is my gift to you to make the learning curve less steep after your diagnosis. The information in this podcast could save your life as it has others. Well, I am so excited to have you here today, Jane McLelland. We're going to talk about how to start cancer. And with that, then we have to address all these different drivers that are then driving and pushing the cancer forward. So tell me a little bit about your journey. I know you told it a gazillion times, but just kind of briefly go through your journey and how you came about understanding how important all of this was.
Yeah, well, I mean, I knew nothing about cancer metabolism or anything like that when I was first diagnosed. And that was way back in 94. And I was only 30 years old at that point. So I very young, had no idea what was going on. I just was diagnosed with cervical cancer. It was like a huge catalogue of errors from the medical perspective. They'd been missing all sorts of, the abnormal smears and things I'd had. They kind of brushed off and told me it was fine. And then I had biopsies, which were allegedly taken from the wrong areas. And I had a slightly rogue doctor. Anyway, I ended up having pretty advanced cancer. It spread to my lymph nodes. So I had the usual kind of stuff. I had chemo surgery and radiotherapy. And then it came back in 1999 in my lungs. That was pretty scary because I just watched my mother die in 96. So between me having my first bout of cancer, she then had stage 4. She died, and really that woke me up to sort of trying to do more things and made me realize that I was on the cusp really of being in the same situation. So when it hit me, I was in a way more prepared. I still didn't know enough, but I'd started to look into the work I knew about Otto Warburg, and I didn't fully comprehend everything back then. I was still very much a sort of, I had L plates on my back, and I really had to learn quite a lot. But my information really came from quizzing the integrative doctors, because there was very little on the net, very little information there was no Facebook or anything like that. So it was very much having to ask people directly what they thought and trying to glean as much information, but really understanding the drivers and understanding what was fueling my cancer was something that has it became more obvious once I understood Otto Warburg's work and understanding that sugar, glucose was a major driver for cancer. I sort of did a low glycemic diet and I did all of that, but that actually wasn't enough. I had intravenous vitamin C, which again actually helps to block some of those glycolytic pathways, those glucose pathways that fuel the cancer. Wasn't enough. In 2003, I then started getting changes in my blood. And this is a secondary effect from the chemo and the radiotherapy that I'd had. So this was changing my bone marrow, which was becoming cancerous. And so then I sort of stepped it up a level. I found I've been reading things like Life Extension magazine, which was fabulous, and the Townsend letter for doctors and patients. You probably have both of those. But anyway, it was just one of my sources of information. And I was visiting hospital libraries and flicking through stuff as well, just trying to find bits of information here, there, and sort of sticking together my program. I had a huge number of supplements I was taking. I didn't know whether they were doing anything or not. It was just a sort of, they were keeping my markers, my SCC, my squamous cell antigen markers below normal for a long time. But this myelodysplasia was a completely new thing, and it shot up something called my TM2PK, which is a marker of glycolysis in the blood. A pyruvate kinase is an enzyme that cancer uses to fuel this glucose pathway. So that was a huge alarm bell. I then had a deleted P53 in my blood as well. And all of these things, the genetic, genes are meant to be sort of the primary drivers for cancer. We're going to talk about drivers for cancer. This is kind of what is traditionally thought of as the sort of the drivers of cancer, all the genetic changes. But these, of course, are mostly secondary to the metabolic changes. But anyway, I didn't know any of that. I then stuck in these drugs that I knew would help block some of those pathways. I was very fortunate that my oncologist was on board with prescribing 2 of those. So she prescribed me lovastatin, which is for cholesterol, generally for cholesterol lowering, but it does have anti-cancer effects. She also prescribed me etodolac, which is a non-steroidal anti-inflammatory. I'd read in Life Extension that the combination of the 2 was better than individually. And I'd actually gone to Gastrology, one of the big publications, and the PubMed article, but I'd found that and seen that actually it made it 5 times more effective at killing the cancer cell if you took them both together. So that was sort of a key thing. Then I added dipridamol, which was something I got from my integrative doctor, Dr. Calaboo, who sadly passed away about 5 months ago, which is tragic because we don't have enough doctors in the UK prescribing these things. But the dipridamol, I didn't realise, was blocking an alternative cholesterol pathway to the cholesterol pathway that the statin blocks, and actually makes the statin even more effective at killing the cancer because it makes it much more sensitive. So it blocks its alternative pathway, if you know what I mean. So it's a sort of an alternative route that cancer uses, because cancer, the reason we can't get rid of cancer very easily is because of its metabolic flexibility, its ability to switch from one pathway to another. And all cancer cells actually need to have cholesterol blobs on their surface, because otherwise they're not human cancers, they're something else. So, but all human cancers have to have these cholesterol blobs on them. In fact, some cancers, like prostate cancer, actually create cholesterol inside the cell as well. So, and they have blobs of cholesterol inside the cell too. So different cancers will express themselves in different ways. But my cancer very much responded to my cocktail. So within, a few months, it had disappeared. My markers went straight back to normal. But then I didn't take them for very long, because I didn't know what I was doing. I was literally just having a go at this experiment on myself. And then the next year, my markers all went up, and my SCC markers started to go up as well, sort of an exponential way, which was, and unfortunately, I've been tracking these things very carefully. So I was right on it from the word that I sort of, I knew it was going up. So I immediately reinstigated my little cocktail again, without the etodolac this time, actually, because I was a bit worried about my stomach taking non-steroidals too long. But anyway, worked to treat. 7 months later, no sign of cancer anywhere. And thank God, touching wood, nothing since, So,
and you're here talking about it.
And I'm here talking about it. And and since then, obviously, I've dug into it. I've tried to help umpteen people, try to get a cocktail of off-label drugs to sort of assist their traditional approach. I'm not the kind of person who says, stop doing your traditional stuff. That's not me at all. I'm sort of, yes, chemo will help. It'll help get rid of those fast dividing cells. We all need to knock back the fast dividing cells. And if we don't do that, particularly aggressive cancers, sure, if you've got a sort of stage 1 or stage 2 where it's not dividing that fast, you can maybe afford to do a bit more of the sort of the complementary side. But once you have a stage 3 or 4, situation's a little bit more urgent, let's say, and you actually need to throw more into the pot in order to actually get a better outcome. So I've been trying to help people for many, many years with their cocktails, and I was really, really failing. People would go to their oncologists and they're, just completely ignored. I've had certain situations, which I wrote about in my book, that were less than favourable responses from the oncologist. So it all made it very tricky. And, I was so delighted to find the Care Oncology Clinic, who are doing a similar cocktail to mine, and, and to find people like yourself who are actually on board with the and have known about this metabolic side, because I really thought by now we would have a completely different oncology system, but it's so slow to change, and how much do you have to do to persuade the oncologists to look beyond their original training, which doesn't even include looking at nutrition properly, and diet and lifestyle factors are massive. And they're still suggesting that people don't change their diets, that they don't do anything different, and that they just have their chemo and their radiotherapy and be good little patients, and off they go and do as they're told, and stuff their faces with cream cakes and donuts. And it's a disastrous situation that can only go one way. And no wonder stage 4 is seen as terminal, because we're not embracing it in a holistic way.
And that is so fascinating, because you have normal medical therapies. They have their standard of care, and that shift so slow, even though you have all this research that's going on, but standard of care in itself shifts so slow. And then you go into the oncology side, and that's even slower. That takes a massive effort to create a shift. And here you have these repurposed drugs that have been around. It's not like we just are finding out about it. There's so much research about it going on PubMed, and you can type in your cancer, type in PubMed, and then you get all this research that is there, but still it's not being recognized. People are still not knowing about it. Doctors are still not prescribing it. Oncologists are still not recognizing it. So, your work is so tremendous to try to move this huge boulder up the hill.
I know. And I feel like there is a massive pushback right now from Big Pharma. Like they're coming out with information on trials that are run purely on one of the drugs, like metformin. The Medscape article came out a couple of weeks ago saying metformin bombs. They use the word bombs in landmark trial and this sort of thing. And it sounds like, just don't touch it. It's just going to cause so many problems. But, when you delve into it, you find actually it was useful for HER2 patients, even on its own. But we know that it doesn't work properly on its own because it's doing other things. It's all drugs, all supplements, all have alternative routes for the cancer to use. None of them target absolutely everything. It just doesn't happen. It doesn't matter whether you're talking about berberine, for example, which is a natural alternative to metformin, or metformin itself, or statins, or dipridamol. They all trigger something else to work as an alternative route for cancer to escape and actually sort of rewire itself. So it's important to know every trial that you look at, or every study that is just done on one drug, is never going to give you the full picture, ever.
Yeah, and that's a key, is that, like you're saying, all cancers are metabolically flexible, which means that if you give pushback in one area, they're going to find 10 other pathways. So it's really important to understand your own cancer. And obviously, there are certain drugs that are beneficial for the majority of cancer, but then there are specific ones for the ones that you're dealing with yourself. And you can then, like you were doing, you're bringing in the cocktail, monitoring, and then seeing how you're responding. If it's not responding, then you shift it a little bit and then see, what is this working better? It doesn't mean that the whole team didn't work. It just means that there may be just different shifts that you can do in order to be able to block all these pathways.
Exactly. And cancer does try and find ways to get around the treatment. So it's important that you don't rest on your laurels thinking you've got the cocktail and that's it. You have got to be wary that it still can rework itself, or that you need to be running tests. And I had a lot of tests done on myself. We were constantly monitoring how I was coping with everything. And I thank God I had some amazing doctors, because they're hard to find. And it took me a while to find them. And if my mother hadn't had cancer before I did, I probably would have been 6 months behind, just trying to find the right doctors, finding the right people to talk to. So that could have cost me my life, those 6 months are just critical, that critical time period when you're diagnosed with stage 4. You've got to know stuff. You really have. And you've got to learn it fast, and that's one of the things. And people do get in a bit of a panic about trying to learn everything straight away. And I've kind of, the Chinese whisper has gone out that, my Metro map, which is all the main key metabolic routes, that people, when they have stage 3 or 4, just block everything, and in a way, that's kind of a statement to say, I said that as sort of a slightly off-cuff remark once, just because people weren't doing enough. They were trying to find 1 or 2 pathways, and it just, I knew that wasn't enough to get them going. So it was like, get on with it, do the cocktail, and then refine it afterwards, because you can work out what the predominant, because every cancer has slightly different dominant pathways that they use. This is why we have different phenotypes that's the way that the cancers express themselves. Lung cancer behaves very differently to lymphomas, to ovarian cancer, to brain cancer. They all have particular ways that they behave. And, traditionally, if we're going to go back to drivers of cancer, obviously, the gene mutations are what the traditional oncologists have looked at for, decades, since I think it was 1960s, they discovered the P53 gene as being implicated in every cancer in one way or another. And because of that, the focus then switched purely to the genetic origins of cancer, rather than Otto Warburg's work, which is effectively just sort of written off and forgotten at that point. A terrible shame, because of course it's, proto-oncogenes, suppressor genes, they're all responsible for driving cancer. And yes, you have to pay attention to them. But actually, when you look at it, they actually drive different metabolic processes in the cancer. So the P53, for example, will drive glycolysis, which is that fermentation of glucose. It'll also lead to more of an uptake of glutamine, which is an amino acid, so a protein. And that actually drives the P53 changes. Plus, it also drives ferroptosis, a sort of resistance to ferroptosis. So it affects the uptake of cysteine in the cell as well. So there are lots of different ways that cancer is driven. My latest edition of my book included that whole thing on ferroptosis and the implication of iron for driving cancer. And that I think is actually a key factor for the more aggressive your cancer is, the more it needs iron. So actually it becomes much more of an Achilles heel that you can use to target it, which is why ferroptosis has been found to be more effective in triple negative breast cancer, in pancreatic cancers, and they're even trying it in brain cancers as well now. But this is all about using iron to trigger a sort of an explosion of oxidation in the cancer, and cancer just does not like any kind of oxygen. It helps to destroy it. So this is it's a new variant on trying to sort of kill the cancer just by using the traditional approaches. It's a slightly divergent path, but it's causing cancer cell death in a different way to apoptosis. Apoptosis is traditionally what cancer oncologists will try and stimulate when they're giving you their treatments. But when you have stage 4, it becomes resistant to apoptosis. So ferroptosis, which is a different cell death, is kind of like a new thing. So it's not new.
Yeah, and we, in the integrative space, like as a naturopathic doctor, you've been using things like artesunate, in order to be able to drive this process where you trigger oxidation, because cancer cells is very iron hungry. They like copper, they like iron, and then be able to utilize that and trigger that oxidation through different methods. So what are some of the kind of repurposed drugs that would, push that ferroptosis?
Well, you've got sulfasalazine is kind of like a classic drug for that. And in fact, the IC50, the amount of sulfasalazine that you need to trigger that, classically, they thought it was 500 milligrams 4 times a day. And you have to be quite regular in how you give that. But actually, when you go on a ketogenic diet or you go on a very low glycemic diet, that comes right down. Ahmed Al-Saka has done some work on that in Egypt, where he's shown it really brings down the quantity of sulfasalazine that you need to give the patient. The dose becomes much lower if you're on a low glycemic diet. So that's a classic drug. Disulfiram, which also known as Antabuse, which is given to patients to stop them craving alcohol. It gives you the most horrendous hangover if you have any alcohol. But that's a drug that's an off-label drug that really helps to promote ferroptosis. And I thought that works particularly well. I've seen it work really well in breast cancer patients, alongside some other things as well with metformin. But interestingly, if you add mebendazole with disulfiram and metformin, it wipes out the benefits completely.
Oh,
I know, that's a surprise finding, but yeah. So, and the reason for that is it makes one of the it's upregulating a pathway that you don't want, which is nuclear factor kappa beta in a kind of a big way, or it's a sort of a sub pathway of that, which you could knock out again with the sulfasalazine. If you added that on top, then you'd probably get back to a really good cocktail. But it's interesting that, you have got to be aware of the sort of the pathways that the cancer will upregulate that you don't want and know how to block those so that you get a really good overall cocktail. And thank God the research is coming out. They're doing the research on what pathways are being left open when you use these old drugs, and they are brilliant in that these old drugs will target multiple pathways, but there are still some that get left open. So yes, they're great, but on the other hand, you've just got to be a little bit wary of the fact that there are some times when you just have to be aware that, you might make things worse unless you're actually blocking something else.
Mm-hmm.
And I know a lot of people are on either fenbendazole or mebendazole. So if you're taking disulfiram and metformin, just be aware that might not be a great cocktail. You might be better off taking the mebendazole out unless you're on sulfasalazine, in which case it would probably be fine.
And still your kind of basic or foundational cocktail that contains also like doxycycline and lovastatin, atorvastatin. Do they work well then with the disulfiram? They
work very well together. So you don't see that with that particular cocktail. Mostly they are synergistic. So, for example, metformin was shown with breast cancer patients that it would actually stimulate fatty acid oxidation as an alternative route for cancer to use. And of course, doxycycline blocks that. So doxycycline and metformin together make a very good cocktail for breast cancer patients in particular. And people forget that metformin is actually quite anti-estrogenic as well. It helps dampen down that estrogen signaling. So for any of the hormonal cancers, even prostate cancer, it's very good for helping damp down some of the hormonal signaling.
And people that are then scared about metformin and liver and kidneys. What do you say to them?
Yeah, well, obviously I'm not a doctor, so I can't.
I know.
But I have talked to doctors. There is a lot of rumor that metformin causes liver damage, but in fact, when you look at it and look at the research, it doesn't hold true at all. And in fact, metformin is used for liver conditions, as are statins. Actually, they can be used for liver conditions as well. Although statins are much more likely to raise your liver enzymes than metformin won't. Metformin actually helps to block gluconeogenesis, which is producing sugar from alternative fuel like fat. So you store fat in the liver and the liver converts it into sugar when you're going through a fast. So in order to block that and keep your sugar levels low, metformin is really, really useful for actually keeping an extra level of starving your cancer, which is obviously what I'm all about, is starving the cancer. And metformin is particularly useful at doing that. Berberine, I think, does to a certain extent as well, but I think metformin is much more effective at doing that.
And that, like you're talking about the Otto Warburg effect, where the cancers and shifting towards fermentation, pushing them, signaling like the lactate, trigger signaling, and also upregulate the usage of glutamates and cysteine and all these kind of things. So metformin becomes a key player in all of these things, along then with other type, like you're saying, other blockers as well.
Yeah, exactly. And metformin has multiple targets. So it helps to reduce IGF-1, which is one of the growth factors, which is very much protein driven. Dairy, meat, all trigger IGF-1, and metformin lowers it down. So it's it's really important to know that, although it can upregulate IGF-2, but you can block that with a supplement called Bakelite. So again, it's sort of knowing the alternative shift that cancer is going to use. And it does mean that your cocktail builds up a little bit. But, this is the answer. Cancer is not a straightforward process. It's not a matter of just wiping out your fast dividing cells with chemo and radiotherapy. Unfortunately, that's not going to get rid of the cancer stem cells, because they divide much slower, and they're the ones that are left behind. They're the really hungry ones. They actually swell up enormously, and then they create these new resistant tumors. So they're the ones that we really need to be targeting, and not the fast dividing cells as the priority. Actually the cancer stem cell is really the priority, but getting rid of the fast dividing cell is important too.
And it all looks so good. You do the chemo radiation originally, and you see all this shrinkage, and everybody do their happy dance. We're winning. And then boom, it's back again. And it's exactly for this very purpose, is that they are not blocking the cancer stem cells. They are not looking at all the different drivers that's feeding this cancer. So you need to, if you're doing chemo, it is crucial to look at the cancer drivers as well. And a great beginning because I know everyone watching and listening, that they hear all these different repurposed drugs, and they, in their mind, they're thinking, how am I going to do this? How here I'm dealing with cancer. She has all this knowledge, Jane McLelland. So where do I start? And I'll point where a very good place to start, and that is right here. This is where you documented your journey. This is the foundation. This is where people can find the Metro map, where they can kind of map out the drivers that relates them to their cancer, and then see what are some of these repurposed drugs, so that they can create a structure in order to be able to look at, how do I block my cancer? So I know that when you're dealing with cancer, everything's overwhelming. Where do I go? Where do I start? And this is like the foundation, to start here. And then you have a bunch of other resources as well, right? That people can reach out to.
Yeah, I've now got a very popular online course. And the reason it's popular is because it breaks down that book into much more digestible chunks, if you know what I mean. I've done loads of little videos. So about, some of them are only as short as sort of 2 or 3 minutes. Others are about 10 minutes. But they literally talk about one little subject or one little pathway, and then ways to block it, and also the type of cancer that tends to use that pathway, so that you can be much more specific. It's kind of like a way of helping you work out your overall cocktail, because of course, there are 200 different types of cancer. I can't possibly say in my book, people criticize me all the time and say, oh, just do one for ovarian cancer, or just do one for but of course you've got different genetic mutations in there as well. And the list of variations is not so extensive, it's not possible. I am trying to work through it slowly, but ultimately I place the onus of control back into the hands of the patient, because I think it's important that they understand their cancer and they understand what it is that's going to help them. Otherwise they won't do it. If you just tell someone, oh, just take these pills, they could trust you and just do it. But if they don't understand why, you're less likely to do it than actually having a full understanding of what it is you're trying to achieve. So my job has been a bit of an educator to try and break down those processes into sort of, and people don't necessarily need to understand what fatty acid oxidation means. You know, do you really need to know that? No, but you need to, if you look in PubMed, you need to understand if it says fatty acid oxidation, you go, okay, well, I know that this and that, you know, doxycycline, mildronate will actually block those. In fact, sodium valproate will help block that too. Damshen, so that you've got a list of options of things, both supplements and off-label drugs that can actually help you block those pathways, so that you know that you're actually creating that symbiotic, that synergistic cocktail that's going to stop it from reworking itself and rewiring so it can escape and resist the treatment. So it is a bit complicated, but it's a way of actually building up your map and your understanding of how it all works. And that's really been my task, is to try and make it more understandable. And this is all stuff I've actually taught myself. You know, nobody taught me how to do it, and this is why I came out with this oversimplified version of the cancer metabolic pathways and sort of how they link to each other. Because I was, you know, the more I looked into the research, the more I could see if you block mTOR, then it stimulates autophagy, and if you block OXPHOS, it stimulates glycolysis, and vice versa. And so, you know, you have these pathways which are very much linked to each other, so you can anticipate what's going to happen. If you give a drug that's only going to block one pathway, you know eventually it'll resist because it's using this other one. So, and the more I looked, the more it became a picture that I felt I could actually put into this little diagram, a schematic, which actually just made it a little bit more visual for people to understand. And when you first look at it, you're a bit flummoxed because there are words that you won't understand, but you know, it'll come to you. It's like learning a new language. Unfortunately, it's just one of those things, and you have got to become your own oncologist when you're diagnosed.
And it's not like, yeah, and I mean, and like you mentioned, it is a bit overwhelming in the beginning, but it's not like you haven't walked this path. I mean, you were there, so it's not like you don't have the understanding of what people are going through, because that was you. And you had to take charge of your life and recognizing that what doctors were doing was not enough, and it was not going to be enough. Yeah, seeing the outcome of what your mother went through. And so people that are in the same place as you were, they need to take the same step and take charge, and then, you know, do the reading. And I love your videos. They're very easy to digest. Yes, they are very short, which makes it nice. You can just, you pop in every day. You can just do a couple of videos and then digest that and see how that relates to you and your process. And so, that's a fantastic program. And where would they go to be able to find these videos, this program?
They're on Teachable. If you look up how to starve cancer, teachable.com, it'll flash up my online course, or you can go to my website, which is howtostarvecancer.com, and I've got links to my book and my online course there as well. So yeah. Well,
Jane, I know you're working tirelessly. So, people saying, well, why don't you just write for ovarian and for this and for that? I mean, this is you doing all of this, and you're kind of a one lady show, pushing forward for this. So it's only so much, in addition to all the speaking and all these events, like you and I chatting right now. I mean, you're all of that is I mean, you're working tirelessly to help people survive, and your survival from your stage 4 cancer has, I mean, the information and knowledge that you pushed, with your book, with your program, with your, Facebook groups and all of these things. I mean, that is, people are given tools to battle one of the scariest thing of all, which, stage 4 cancer. Yeah. And I'm so grateful for what you're doing, and I'm so glad that you're still alive doing it.
I can't do it all though, and I need doctors like you to be able to help patients, because I can't prescribe. All I can tell people is these things may be useful for you, but I can't actually prescribe those drugs. So I can't, when it comes to stimulating ferroptosis or something, they need intravenous vitamin C. They need possibly artesunate or artemisia, and then they need possibly leflunomide, which is another drug, or they need, there are so many things that could be an option. And this is the thing, there isn't just one route to Rome. There are many, and different doctors can, and this is where the skill of the doctor is important, because, you have skills that you look at things and you look at the tests and you interpret what people's blood results are, and you work out what the best method for treating that person is. And it could be something, it could include mistletoe. It could include, there are so many different options out there that people can use. And this is where I say, you just need a skilled doctor to help you with all of this, particularly if you're using a cocktail of drugs, because traditionally it's, frowned on to have too many drugs in your cocktail. And you certainly need to know that they're not interacting badly or going to do something awful to your system. But, all of the off-label drugs are pretty much very low toxicity. There are some that you have to be a bit more wary about, but essentially, metformin, statin, dipridamol can have some side effects with blood pressure. It can obviously, it's an antiplatelet drug, so it causes blood thinning. So have to be careful with certain types of cancer patients that they don't, bleed too much with those kind of drugs. But yeah, as long as you've got somebody like yourself overlooking the whole program and being able to make sure that they're not, doing anything too dreadful to themselves, then great, fantastic. And to look for interactions between the drugs and to check that there aren't any side effects, unwanted side effects from what you're doing. But essentially, when you look at chemo and you compare that and the, other toxic immunotherapy drugs that people are given, I'm not saying don't do immunotherapy. There are ways to make these things work better. And we know that immunotherapy doesn't work that well, but the side effects can be terrible. You can have hyperprogression, and that's not talked about very much with the immunotherapies. And it's kind of like something that's not really wanted to be discussed, but that can happen just as much as regression with immunotherapies as you can get hyperprogression, which is a terrible thing. And then you get all these itis problems where you get inflammation, maybe pneumonitis or other issues with the immunotherapies. But, you've got to monitor the side effects, and there are ways to calm these down and a way to improve the effect of immunotherapy, because there are certain metabolic pathways that you can block to make them work better as well. Yeah.
I really appreciate you taking this time, and I'm so excited for people having this tool. And so, I urge everyone to go and get your book, How to Start Cancer, and get on to your training, your program, and get going, because this is so fantastic. Thank you so much, Jane. I really appreciate it.
Lovely.
The information in this podcast is for educational purposes only and is not designed to diagnose or treat any disease. If you'd like to know more about what my center offers, please visit thekarlfeldtcenter.com. Please join us next week for another live consultation with a patient diagnosed with cancer on Integrative Cancer Solutions with Dr. Karlfeldt.